Really have like two more topics. We're gonna finish up talking about conventional or normal bone growth, bone remodeling, bone repair, and then we're gonna talk about calcium maintenance. And when I talk about calcium maintenance, I'm talking about there is a combination of how much calcium is in the blood. Is there too much calcium in the blood? Is there too little calcium in the blood? In that process, when you're talking about calcium in the blood, that's negative feedback. Don't get confused by saying that calcium moving into the bone or moving out of the bone, because we'll talk about that today. We're going to talk about calcium coming out of the digestive system or into the urinary system. We're going to talk about that. That part's not negative feedback. So the concentration of calcium in the blood is what's maintained by negative feedback. But before we get to that, we're going to finish this discussion about how our bones, how do they change over time? They're not going to change in length. Unfortunately, so I wanted to be taller than I am. It's not going to happen. The only thing that's going to happen now is I'm going to get shorter. Now, as I get shorter, there's a couple of things that can happen. One of the things that can happen is my articular cartilage could decrease. The space between the bones could decrease, and that could result in overall shortening of the body. If I start working out and I start getting stronger, right, my muscles will increase, and we're going to learn more about how skeletal muscle size increases. But it also will result in bone increasing as well. That bone is not going to lengthen, unfortunately for me. It's not going to get me any taller, but it will widen, and the epiphyses will also strengthen as well. The compact bone will become more substantial. If the compact bone becomes more substantial, that additional bone will be stronger. In contrast, if I don't do this workout, yes.
Can you shrink?
Excuse me?
Like, can you shrink or
I do, yeah, absolutely. I absolutely can shrink.
No,
As a teen?
Yes.
If you're talking like a medical injury,
Like height?
well, so I know a roommate who was 6'6" in high school, and when I met him, he was 6'3" or 6'4". So he was an adult when I met him, right? And he had a problem. He had 2 or 3 vertebral discs removed, and so that caused the vertebrae to come closer, and he lost height. But that's a medical necessity. Generally speaking, if you're a normal, healthy individual, you're not going to significantly shrink,
So
especially as a young person.
So like when
Hold on a second.
sorry.
I lost like a
So, I don't know the answer to why you lost an inch. It might be that there was an error in measuring. That would be most likely what's happened. Right. So, Vin, what were you gonna say?
So bones can only get like wider with exercise, right? Is that what you're saying?
Yeah, so bones are going to get wider. They're going to change in overall strength, maintenance of the body or physical strength, right? And the contrast will happen as well. So this is a combination of osteoclast and osteoblast activity. So building new bone is going to be as the blast and the osteoclast. What I'm going to say in a little bit is they sort of go on their normal daily life. They just sort of keep working. And if you exceed that osteoclast activity, your bones are going to get stronger. If you meet that osteoclast activity that is unwavering, your bones are going to maintain. And if you are less than that osteoclast activity, your bones are going to weaken. If you reduce the stress on bones, then those bones will over time will weaken. I'm not talking about a day or even a couple of weeks. I'm talking about longer times. So those bones will slowly get stronger due to mechanical stress. That mechanical stress will be a result of increased activity, will be a result of the osteoblasts, building new bone.
Dr. Clinton, why do bones, they like form like U shapes? When they grow, they make like dents and they make crevices and like all types of foramens and stuff.
So why do they make foramens? Because you need passageways for blood vessels and nerves. Why do they make bumps and stuff like that? You need connections for muscles and ligaments and tendons.
So your body, they grow around the ligaments and grow around the muscles.
No, so the ligaments have, and tendons have connective tissue that is exact analogous to bone structure, the cellular matrix of the, or the collagenous matrix of bone. And so what you're doing here is you're making the bone, and then you just sort of, let's just continue making the bone, but we're not making bone anymore, we're just making collagen, and then we're gonna make that multi-layered structure that gets really, really thick and dense, and then we're gonna go start surrounding with muscle. So if this is the bone, there's the ligament or the tendon in this case, and then that tendon gets covers the muscle, and then now it's completely seamless. So it's really, really strong.
So, I thought like when someone's like bedbound, when they get weaker, I thought it was only a muscle thing. It's a bone thing too. Like the less you use your bones, the weaker they get.
Correct. The lesser you use the bones, the weaker it gets. But the bones don't change as quickly as muscles do. Okay. So muscles change much more rapidly than the bones.
Okay.
So it's the two things can happen at once. But the more substantial, obvious loss is going to be muscle. Yeah. So let's talk about what happens in, so back when I was in 4th and 5th grade, in September of 4th grade, I broke my arm playing football. September of 5th grade, I broke my arm playing football. And I was left-handed, I broke both left-handed both times. And by the way, I used to have this subject called penmanship, where you have to write out in script and stuff like that. This was a couple years ago. Now, I have my arm like this, and I couldn't even pick up a pencil with it. It was in 5th grade. And Miss Hawkins, I was not happy with her. She gave me a D in penmanship, writing with my right hand.
When were you in 5th grade?
That was last year.
Oh, okay.
That was 2005.
And look at you now, a professor.
2005.
Mr. Doctor, you look good for your age, doctor.
I know that.
We're joking.
No, she was not. She was like,
I was born in 2006, so we grew up.
I know that. That's why I said it. Right? My daughter was born in 2006. Although once I said she'd born in 2007, and she hasn't let me live it down. But back to my broken arm. I broke my arm. First, I broke it at the distal epiphysis, and it got repaired. Then I broke it on the diaphysis, and it got repaired. In both cases now, the bone itself it had to get remodeled. It had to get repaired, and first of all, it had to get set. In 5th grade, I was yelling at the X-ray technician. I can still remember today because my arm was in a splint, and I was telling him that he didn't know how to do his job because he was an idiot, and to stop touching my bleeping arm because I know it's broken. You're an idiot. Just take the X-ray.
Oh wow,
and,
you're a bad kid.
well, I was also in really serious pain.
What was he doing?
He was trying to take this splint off of my arm so he could take the X-ray. And I can still remember to this day, it was hurting like crazy, and I'm screaming at him. I said, just take the bleeping X-ray. I'm 11 years old, and I'm swearing at him, right? And so at this point, the surgeon comes in, and he goes, he yells at the X-ray technician, he goes, leave it alone. And now this is a guy that I knew from last year, because it was my orthopedic last year, too.
Oh, you must have been mad that you broke your arm twice.
Mm-hmm. And he yells at the X-ray technician, he goes, go take the X-ray. And then he goes to me, you. Because I started saying, see, I told you, you don't know what the hell you're doing. Right? And he goes, you. Shut your mouth. Don't do that. And my mother thought he was great, right? So he was really mean to me. But he didn't mess around. So took the X-ray. It turns out my radius and ulna in the diaphysis was broken. If this was the radius and the ulna, my bone was like this, right? So he had to pull it like this, set it like that, and then maintain the structure of it. So there was, this was obviously a traumatic example of mechanical damage. There's a combination of soft tissue damage. There's a lot of problems right here, and it took, I think it was like 2 months that I was in a cast right here. There's all of these tissues right here are classifying, all these characteristics can classify, can tell a physician or a medical professional about the structure of the damage. If you look at the fracture pattern, there's a number of different ways of describing the pattern here. So there could be linear or spiral, there can be an avulsion or stress and compression. There also can be epiphyseal fractures. And if you look at these ones that I've just underlined, those are the ones that I'm going to focus on. So, and again, now there's the spiral, compression, and epiphyseal fractures are all the ones that are ones. So there's complete, so there's a spiral, there, I think I said complete, and I don't have the epiphyseal fracture in this picture. Where would the epiphyseal fracture be? It could be here. In my case, when I was in 4th grade, it was distally here, in this area right here. And if you look at this one right here, an impacted fracture is when there's lots of pressure pushing down on it, right? Typically, the compression fracture, the one that I'm mentioning right here, that I underlined here, the compression fracture typically happens with vertebrae, and it will happen where the superior vertebra pushes down on the inferior vertebrae, compromising the integrity of the vertebral disc. If the vertebral disc is completely compromised, right, then the bones will touch one another, and that's a major problem. So you hear me telling one student who I always say to her, you should be being careful with your legs and your medical issue, right? Well, my daughter has a problem with her S1 and her L5 vertebrae. So her disc is compromised a little bit, and so she has pain in her back. So I'm routinely carrying her bag for her, and she's not very, sometimes she's appreciative, other times she's not when I say to her, stop doing that. But let's just talk about the injury itself, the process. The first thing that happens.
That's what would happen if you were like to jump into a pool feet first, like that, and then just
Something,
and you hit the floor.
yeah, so something like that would happen.
Referring back to fractures, when I was like 7, I had a hairline fracture. Like, what's that?
A hairline fracture
Yeah, like
would be, so it depends on what we're talking about here, but a hairline fracture would be something like this would be an incomplete fracture.
Okay.
So the fractures that I described are complete fractures.
I was just curious, honestly. So I had an incomplete fracture?
Yes. Regardless of the injury, right? The more severe injury, the more time that it takes to repair. But there's a series of responses to this injury. We gotta get through this, okay? There's a series of responses to this injury. The immediate response, regardless of whether it's a minor bone break or a complete bone break, is a hematoma formation. That hema means blood cells, so there's a mass of blood cells that rush to this area. That this urgent process right here, as that urgent process continues, what type of feedback is that going to be?
Negative? No.
Don't say negative.
Positive.
So it's positive feedback. This is an emergency. That process there's a clot that forms. Some of the bone tissue is dying, is getting removed, right? And the process, as that localized blood is released there's platelets, or thrombocytes, there's leukocytes that are going there, and through their processes, they're going to be removing broken tissue that needs to get removed, and then you need to stabilize it. That callus forms. That callus is massive tissue. Typically, it's cartilage that's formed. There's an internal and external callus that forms, and that callus then stabilizes the bone. And then it provides the structure for ossification later on. So in terms of the callus formation right here, what are some of the sites that are working here? So there's macrophage, or cells rather. The macrophage is an osteoclast. There's fibroblasts and chondroblasts and osteoblasts. All of those things are operating. They're building their specific component to this, or rebuilding that specific component to it. So now if I ask you what they're going to be doing here, this is in the context of this repair, you should be able to tell me that. So that part of the callus, again, that's providing the structure for the bone to repair itself. The next thing that's happened here is the callus that was largely cartilage in formation right here. That callus then is replaced by spongy bone. Right? And that's typical spongy bone formation with the trabeculae, and then slowly but surely that spongy bone then is replaced by compact bone, where it's supposed to be, right? And so in other words, my radius and the ulna, when it was repaired here, I have an operating medullary cavity there. So you don't want to build compact bone where the medullary cavity was. You want to build it where it's supposed to be, right? So in other words, you want to do that so that the osteoclast will help sculpt the bone, remove bone that's inappropriate. The osteoblast will be building bone where it's appropriate. So that's called bone remodeling, right? That last step. So this process of bone repair is characteristic here. So here on the left-hand side, we have the hematoma formation with the callus formation, and we talked about, I mentioned just a second ago, or in the on the slides there's an internal and external callus formation. But regardless here, the callus formation here, we're basically making spongy bone here, and then that spongy bone, depending on where it is either removed completely if it's where my pointer is, because it's part of the medullary cavity, or it gets converted to compact bone. That one of the things that does happen, if you look at this, there's a little bit of a bump that's in this drawing right here, and you can see there's a little bit of a bump right here. If this is a broken humerus, I have a little bit of a bump up, especially on my radius. I can feel it, and that callus is present there. And so now this is the last major topic of this discussion of this chapter, and that's calcium maintenance. So calcium maintenance, again, it's a negative feedback in the context of blood plasma concentration of calcium. That's what we're worried about. So calcium, depending on where we are, right, calcium will enter the bone. So if you're taking calcium out of the blood, it's entering the bone via the activities of osteoblasts or osteocytes. If you're taking calcium and you're putting it into the blood, it's the action of either the digestive system or osteoclasts. So depending on where we are. Now, in terms of calcium itself, calcium is important. It plays a significant role in skeletal muscle and cardiac muscle contraction. It plays a role in just sort of overall cell functioning. So if we lack calcium ion in our body, right, that's a problem. Right? So calcium is critical for normal muscle functioning. Without it, our muscles don't function, and that's a problem. Right? So, and you can also see neural signaling. So there's muscles, all different types of muscles, and nervous tissue is affected by levels of calcium in the extracellular fluid. That extracellular fluid is adjacent to the plasma, and therefore that's what we're talking about here, calcium levels in the plasma. There's three major things, one of which we already heard about. Calcitriol is the last one. I've already talked about it. It's something that you should be familiar with. But PTH, or parathyroid hormone, and calcitonin are two hormones that you should recognize and know. You should know where they're coming from and what they do, what their activity is. The first thing is PTH, or parathyroid hormone. In both cases, the parathyroid hormone and the thyroid hormone are produced near the thyroid gland. And if you grab your neck right about here, your hand is a U shape. That's the shape of the thyroid gland. And then deep to the thyroid gland along the axis of the larynx is the parathyroid hormone, or the parathyroid gland. They're dotted. It's very, very small relative to the thyroid gland. And so it produces the parathyroid hormone. So PTH is parathyroid hormone, and it activates osteoclasts. There's that first list. What does it do? It increases the number of osteoclasts, and it activates osteoclasts that are present there. It promotes as a result of it, it increases osteoclast activity. And you see that it also, in the second bullet, releases calcium into the blood. In the process of releasing calcium in the blood, more bone is resorbed on average. And in addition, there's other parts of the, there's two other parts of calcium maintenance that we can deal with, or that we're interested in, just in general. We're not worried about the real specifics, that's for AMP2. The digestive system and the urinary system. So stimulating reabsorption of calcium from the kidney tubules here means that, so if you don't stimulate that, then the calcium is destined for urination, for leaving the body. So right before it gets to the point where it's going to be urinated out or left or leave the body, it gets resorbed. So now we have increased calcium in the blood coming from bones. We have increased calcium from the blood coming from urine here. And then finally, calcitriol. What's calcitriol? Vitamin D. So vitamin D activity here works with PTH. PTH promotes the activity of calcitriol, and that increases calcium absorption in the small intestine. So increased calcium in the small intestine, increased resorption from the what's called the formative urine, or soon-to-be urine, and then taking calcium from the bone. All of this is increasing the levels of calcium in the blood. And I want to stress here, look at what it does here. It can modify the number and the activity levels of osteoclasts. Okay. The thyroid, calcitonin is produced by the thyroid gland. Calcitonin is, overall, its activity is to decrease blood calcium levels. Now, if you look at this, at first glance, you'd say, it says, inhibit osteoclast activities, but it doesn't turn it off. Right? So it doesn't turn it off. So there's always this recurrent theme of this osteoclast activity is churning along. And once again, and that's something that I'll talk about later on. So it decreases osteoclast activity, it doesn't turn it off. It increases calcium ion excretion, so that lowers the amount of calcium in the blood, increases the amount in the urine, decreases the amount in the intestines here, and the first bullet here, where my pointer is the point where this is. More calcium is kept in the bones.
So, calcitonin is like the opposite of the parathyroid hormone.
So almost exactly, yes. And this is an example of negative feedback. Okay, but it's negative feedback in the blood, not negative feedback in the bone or the digestive system or the urinary system. Yes.
So, sorry. So it would be like it increases the calcium levels in the blood, but no, actually, no.
You okay?
Yeah.
And this is just, if you look at where my pointer is right here, this is sort of the classic description of, remember now, this is what I'm talking about from chapter 1, where there's set points, there's control centers, there's effectors, and there's sensors right here. That's the language that I used in chapter 1. I expect that you should be able to use that same language based on and apply it to this example. In this case now, the set point here is a certain level of calcium concentration in the blood plasma. If it exceeds that level, then one thing is going to happen. If it is less than that level, then another thing is going to happen. And you should be able to recognize that, right? So that if you want to lower blood calcium levels, then this is what's happening, right? If you want to increase blood calcium levels, this is what's going to happen. Once again, now calcium, the huge, basically, we have an enormous supply or storage of calcium in our body, in our bones. So we can really, this can really go on for a long time, this level of calcium maintenance, because we have so much in our bones. So it's a combination of these three hormones. There's PTH, or parathyroid hormone, calcitonin, and calcitriol. Okay? I said a little while ago that osteoclast activity doesn't get turned off in this whole process right here. Osteoblast activity can be turned off, or nearly turned off, not completely turned off. Osteocyte activity doesn't really affect this a lot because osteocytes there are enclosed, they don't have a huge ability to add new bone. They're going to be enclosed already, so they're really not at play here. So now, over decades now. So if you're if you're a CNA and you have a patient who's older and they haven't walked a lot over the last decade or 2 decades, right? They're not very active. The likelihood that their osteoblasts are active is pretty low, but the osteoclasts continue on more or less unabated. They don't get changed very much, so as a result, you have greater influence of osteoclasts than osteoblasts. So this can lead to porous bones and loss of bone matrix. What is the bone matrix? That's the structure of the bone that I've been talking about. That porous bones is called osteoporosis, and it tends to affect women, older women more than men. You can have some medication that can exacerbate that, but you can also have other medications that can fix it too, or help repair it. First of all, there's a series of questions on the left, but let's look at the pictures on the right here. What type of bone are we looking at? On a spongy bone. So which type of bone is going to be most affected by osteoporosis? Is it going to be compact bone or spongy bone, do you think? Spongy bone. So now, where is the spongy bone going to be affecting? Where are the bones going to be most impacted on a long bone? It's going to be on the proximal or the distal epiphysis. And in particular, if you've ever heard or seen anyone getting fractures of the hips, fractures of the femur, of the proximal epiphysis of the femur, that's where we're talking about here. In the picture right here, on the left-hand side is normal, healthy, spongy bone, and on the right-hand side is compromised. So you can see that there's 5 questions there. Which one is most likely to be osteoporotic? The one on the right, and you can see the other ones. So this osteoporosis is this sort of a chronic condition, and you can see this lower picture here, this older woman with this bone with osteoporotic. There's pores in the individual trabeculae. The osteoclast activity is greater than the osteoblast activity, and that results in the weakening of the bone.
So osteoporosis is literally holes in the bones.
Yes. Holes in the bone. The bones, basically the osteoclasts are drilling holes in the bones and they're not getting replaced. At the top here, the osteoclasts are still drilling holes in the bone, but as they get drilled holes in the bone, the osteoblasts are going back and filling them in. Right? And so everything's fine. So it's balanced. That's right. It's balanced. So now if it's perfectly balanced, then there's no change in bone levels. If the osteoblasts are more active than the osteoclasts, then there's adding of bone. And then at the bottom is when the reverse happens, when osteoclasts are better, more activity. And this sort of, there's the osteoporosis is a number of different things that can affect it. I hate this part. Talking about in 100 years when I'm old, my bones will be more brittle due to lack of collagen. My bones will have less hydroxyapatite. If it's got less hydroxyapatite, it'll have less calcium. If it has less calcium, it'll be weaker overall. The collagen itself will be less flexible and less dramatic. So as a result, it's going to be it'll be weaker. As a result, so I can lose some height, right? So some of the bone will change in height, but majority of the bone of height changes. It's not due to bone length changes, but it's due to cartilage, particular articular cartilage. And then we can talk about arthritis, which is right here. Arthritis is when 2 bones come together, and there's 3 different categories of it. There's osteoarthritis, rheumatoid arthritis, and gouty arthritis. That last one, gout or gouty arthritis, used to be fairly common in particularly wealthy individuals because it's a result of diet or partially a consequence of diet. One of the things that it does is that these crystals that are found that are accumulate from the diet, if you eat a diet of lots of alcohol and very, very fatty foods with a lot of organ meat, all of which like sort of royalty used to have. That's what you do too?
Oh, no, I'm gonna.
Oh, you have a question. What's your question?
With carpal tunnel, like, what is that just like, I don't know, is that the
So-
bones?
So carpal tunnel is not what we're talking about here. So carpal tunnel here is a condition where your hand, you have a series of blood vessels and nerves that go down the arm and they go to the hand, right? And right about here is where there's this tendinous structure that forms a tunnel. And if there's swelling in that tendinous structure, it pushes pressure on the stuff inside. What's on the stuff inside? Blood vessels and nerves. And so if you have carpal tunnel, my wife had carpal tunnel syndrome. What the doctor did was he literally just put a little incision right here. He goes in, clips that tendinous package there that holds everything together, gives it a little bit space, and my wife's like, oh, this is awesome. I wish I'd done it years and years ago. But that's not a result of bone friction here. That's a result of swelling from the tendinous material here that's holding it in. And so that's restricting the amount of blood flow there. So typically your hands will go numb and you'll have pain in your hands. Okay.
So is gouty arthritis, that's related to gout, right?
Yes.
Okay.
And the classic example of gout is in the hallux here, in the base of the hallux, between the metatarsal and the proximal phalange. There's swelling right there. Crystals from the diet go into the blood plasma, and it accumulates there, and it hurts. A long, long time ago. So my nephew is in his early 30s. When his dad had him, he had gout, and he's my older brother. And I was like, hey, Bill, how's Sean doing? Sean's my nephew. And, we're talking about Sean. I was like, hey, so how are you doing, Dad? And he was like, oh, it's tired. My foot's killing me. I was like, really? Get the hell out. What happened? And he said, he has gout. I said, holy crap, I do too. It was right foot. He had it, so he lives in New Jersey. I live in Rhode Island. It was my right foot. It was his right foot. It was totally coincidental. And I haven't had it since. I don't know where the hell I got it from. But it was a pain. It was really, really painful. I was 6 years old at that point. It was really, really ridiculous painful. I was living on my own and everything.
At 6?
Yeah.
At least you're listening. So that's good, right? But no, I wasn't 6. So that's one example of arthritis here. In contrast, now arthritis, regardless of what we're talking about here, it's where the bone and the bone cavity is compromised, the space between the bones is compromised, and as a result, there's pain there.
So it's like bone on bone.
It's like bone on bone. In this case, it's not because the structure of the bone is not, the cavity is not, but there's crystals that cause the bones to have friction. Rheumatoid arthritis is the articular cartilage is removed by the body. It's an immune response typically, and it changes the articulation, the structure of the joint. And so you can see hands that are fingers that are all over the place, and it's very, very painful to a person. But that's largely an immune response. And the last one is osteoarthritis, and this is a result of age. Typically, osteoarthritis is that overuse. Older people, again, the cartilage declines in that and ability to withstand friction. So since I'm 138, I'm starting to get osteoarthritis.
Starting?
The one that's most common, the one that I'll ask most about is osteoarthritis. If you look at these two articulations, first of all, where are they in the body?
The joint, the leg.
We don't have legs. What articulation? What is this?
That's the femur.
That's the femur.
No.
The huge.
Femur. No.
That's the humerus.
Femur. Is that, yeah.
Cooked.
What?
So
What?
let's look, we're just focused on the left side. What bone is that?
The
Don't say humerus.
femur.
Femur. What bone is that?
Tibia. The tib.
So there's two bones that are distal on the leg. There's a large one and a smaller one. What's the smaller one called? Fibula. And this is the tibia.
The tibia.
Now, what side of the body is this from?
Left.
So left or right? This is a posterior view because you don't really see the patella very well. So let's just say it's a posterior view.
This is the left, right?
Okay. It's left or right. How do you know?
Well, because the fibula's on the outside, then it would be.
So this has to be lateral. If this is lateral,
Oh, that's the right
this is
side.
medial. Okay, if this is a posterior view, and I'm pretty sure that it is, you can see this part right here. See this darkening right here? This is not darkening of the bone of the tibia, of the femur. This is a darkening due to the patella. The patella, I think, is in front. I'm not a radiologist, but I think that's true. So this is not this way. It's this way.
The right.
This is lateral. It's got to be that way because otherwise it'll be on this side. Okay, so this would be the right side. Does this articulation have any arthritis obvious?
No.
No. If you look on the right, that one does. Right? And it could be due to a number of things. It could be damage.
Those are two different x-rays?
These are different x-rays, different
Okay.
people.
Okay.
If you look at the, on the right-hand side again, on the left-hand side is that original picture here. That narrowing of the joint itself, and we'll talk about the cavity itself later on in the next unit, but that narrowing of the joint results in the widening of the joint on the other side, and so there'll be a lot of pain medially relative to
Could
the
it
lateral.
happen on both sides, or does it normally just happen on like one side?
It depends on the reason for the arthritis. So if it's an injury-related thing, it could be one side or the other. If it's overall just sort of age, it's probably bilateral. In other words, it's probably both sides. Someone mentioned earlier about the effect of.
We do not have this on our slides.
Yeah, I know. I literally just added it just 5 minutes ago, and the previous break. So, what happens when bone growth doesn't turn off? Right? What happens when bone growth turns off too early? Right? So there's obvious examples here. I have another slide somewhere, and I don't know where the heck it is. But this guy, I forgot his name now.
Didn't he have
Robert
glasses?
Wadlow, I think his name is.
Didn't he have like glasses? I thought he had glasses.
Yeah, I said, well, you don't have to wear glasses for every picture, right?
No, I know, but like I'm just saying.
Dr. Clancy? So technically, right, for bone growth, it's more of a hormonal reproductive thing rather than a gene thing. Like, you know how like people think they get their height from their parents? Like, is it more due to your body doing its own thing or more of a genetic thing?
So virtually everything that you're asking, so you can ask everything about yourself, about you versus your parents, you or your entire heritage, right? Is a combination of genes and environment. So if you have a very, very good diet and you have very, very good health care, the likelihood that you're taller than your ancestors is much higher, right? So regardless of what your genetics are, right? Now,
But like, does genetics influence the secretion of growth hormone?
so
Right.
I was just going to say this. Now,
That's a good
how
point.
many people think that my son is a 6'10" black kid?
What the
Now,
hell?
wait a minute here. I'm not. So now, listen. I'm not trying to get into race, right? But my genetics. So I definitely have a baby, right? He's my biological child. So in other words, my wife wasn't stepping out on me. Okay. All right. So in all likelihood, he's not African American. He's not dark skinned. I'm sort of light skinned, although my wife is much darker skinned than me. But he's not light skinned, and he's probably not tall. Right? So that's dictated the genetics. So there's definitely an interplay between the genes and the environment. Right? Now, can you have a kid that is much, much taller than your parents or much, much shorter than your parents? Absolutely, right? But that's also a combination of, it's probably a combination of genes and then the environment in general. Yes?
So, is that the answer? Then, like, your hormone growth and your
So your hormones definitely dictate how rapidly you grow, when you start puberty, when you start actively growing those bones, right? They definitely do. In particular, I'm not going to ask you this. So just the hormones are but generally, in particular, it's called your pituitary gland. So as your pituitary gland starting that activity, that transformation from a kid to through puberty into an adult, that is definitely going to be part of it. Right? There's no question about it. But it's also there's other factors too. All right. So, any questions about what we've talked about today?
Nope.
Now, let's talk about what the quiz is going to be on. Okay.
Chapter 5 and 6.
So there's 2 chapters. Which chapter is more detailed?
6.
6 or 5?
6.
6. So 6 will have about 20 questions. 5 will have about 10 questions. Okay? Total of 30 questions. The quiz will be on Monday at 8:30. The quiz will be on Monday at 8:30. After the quiz, we're going to have a discussion about the axial skeleton. The axial skeleton will come in 2 varieties. We'll talk about the skull and the vertebrae. We'll definitely get through the skull. We'll probably wait on the vertebrae. But we're going to have a lecture after that. We have to get through that lecture because we're rushing through next week to the following Tuesday to our next exam. Okay? I can't stress enough. You guys have 4 days. You all should kill this quiz. Right? You should all get, I want you to all get 28s, 29s, or 30s.
What?
Okay? Out of 30 questions. Okay?
Yeah.
But wait, so can I just say one more thing? So you have 4 days to study this and learn it, or you have 4 days to not study it and forget it. The choice is yours. I can absolutely tell you that if the quizzes that you've taken so far were hard, this one is going to be significantly harder. Okay? I told you, the first day of class, I said, you're going to wish to go, you went back to exam 1. But I'm not kidding. What I typically see is quiz grades go down.